I am really excited about this next session. First of all, I want to thank Michigan HIMSS. Michigan HIMSS is one of our diamond sponsors. They've been a co-partner with us on most of these things for quite some time. And I guess, wow, did they deliver this year. And the next thing I want to do is I want to introduce two people, both of whom probably don't need much introduction. One is Carla Smith, who's the Executive Vice President for HIMSS, and Dr. Karen DeSalvo, who also probably needs no introduction, who is the Acting Assistant Secretary for Health and Human Services and in charge of ONC. The next thing I want to say is thank you both. The commitment to Michigan is genuine and real. For those of you who were here last night, we cannot thank everyone enough for really wanting to roll up their sleeves and do something here. The second thing I want to do is I want to thank your staff, both your staffs, who've been awesome to work with, who've been truly professional and made a commitment to come here to Michigan as well and help us prep and continue to do follow-up. So thank you very much. With that, I will step off the stage and let you two.
Sure. Tim, thank you. Thank you so much. So I'm Carla Smith. I'm Executive Vice President with HIMSS, and it is very easy for me personally to have a commitment to Michigan because I live here. My family and I, we live in Ann Arbor, Michigan. We live on the north side of town. I got my undergrad degree from Adrian College. Though I didn't grow up in Michigan, I've spent my entire adult life here, got my graduate degree from Michigan. So I am delighted to be here and to be able to be talking about the best use of information technology to support communities and the health of populations within the communities. And the genesis of what I'm about to talk with you about and explain what we've been working on upstairs for the better part of the day came out of a conversation that Karen and I had 7 weeks ago, not that long ago, pretty recently, where when Karen came into the meeting that I was part of, she explained that she had just had her daily Flint call. And so I inquired a little bit about that and learned that she's on the telephone every morning, 7 days a week, talking about the Flint water crisis and HHS's involvement in helping to protect the health of the population in Flint, Michigan. And so we started talking that through, and out of that came this genesis of an idea of some kind of a playbook or guidance document or roadmap that communities could use to prepare for and be ready for a public health crisis. Because you never know where it's going to come from. It could be human created, like the crisis that we have faced here in Michigan in Flint. It can be a natural disaster like what Karen lived through with Hurricane Katrina in New Orleans. There are several components of it. You've got prevention, you've got detection, and you've got intervention. And it's important as learning health system in order to be ready at all of those levels. So what we've been working on upstairs today, and Karen's team has been part of this, and the HIMSS team has been part of it, is a program that was actually supported and launched by the Michigan HIMSS chapter. They did all of the heavy lifting for this workshop that we just held upstairs. We have now laid the very beginnings of a framework for a guidance document. And that guidance document, we are going to go live probably in the December timeframe. We're going to workshop this guidance framework, community-based guidance framework, with other chapters of HIMSS in which communities have experienced or are experiencing a public health crisis. So for example, both Karen's team and my team have been getting continuous outreach recently from Puerto Rico, professionals in Puerto Rico who are facing a Zika epidemic. HIMSS has a chapter in Puerto Rico. So that is a location for a possible workshop to continue rolling out and refining this guidance document. So let me tell you just a little bit about what's inside of it. The version 1 of it has 6 components. You have the infrastructure and the technology tools components. You have the care management and care coordination and treatment component, research, population health, consumer access to information, and community communication. So within all of those, what we workshopped upstairs today were the beginnings of a framework for each of those areas. And so, for example, of identifying the problem from various angles, doing a gap analysis, building the relationships within the community so that you can be ready to be preparing constantly, to be practicing, to be drilling. In the health sector, there is tremendous discipline already. You've already been trained and educated on emergency response and emergency preparedness. It is taking knowledge that you already have and training that you've already had, and now evolving that and using it in new ways for community preparedness to prevent a public health crisis, to detect a public health crisis, and to respond effectively using the best use of information technology. With that, I want to take a pause. I want to open it up for Karen to talk about, from a national perspective, some of the frameworks and the leadership that she has shown and how this fits in to your work at HHS.
Well, thank you, Carla. And I want to reiterate what you said about thanks to the HIMSS Michigan chapter, to your folks in North America, and to my team, who I'll embarrass again by asking them to stand up. The folks from the Office of the National Coordinator, and if Kathleen Falk, the Regional Director for Region 5, is still here, just so people can see your faces and grab you and know you. We work for you guys, and so you ought to know who we are. Mm-hmm. I want to just begin by emphasizing how important it is to the administration that we are here to support Michigan and the community of Flint as the crisis is addressed, but also in recovery. The President asked Health and Human Services to be the lead agency in the water crisis in Flint, considering it was a public health event, and asked Dr. Nicole Lurie, the Assistant Secretary for Preparedness and Response, to be the federal official in charge. I've had the chance to help Dr. Lurie in this effort, focusing on the public health components in particular, but also, I think, lending wherever I had a prior experience from community rebuilding in work I've done in Katrina and otherwise, and been able to visit Flint several times, and been now to Lansing a couple of times. And I think what I want to convey first, just as an administration message and a partially personal message, is how much we are continuing to be engaged and invested, and want to see that we do everything to support Flint and Michigan in a move forward motion, so that we take every opportunity that we have to provide support, to flex and bend, but to also help realize what I hear a lot from the community here, which is that this may be an opportunity for there to be some change or some rapid evolution of some vision that everyone has had. And so I just want to underscore again that we're here today, but it's not been just one stop. We've been here many times, and we'll be back, and we'll be continuing to be supportive. I think Carla describes well that there is a real opportunity for Michigan and for Flint to show the way to particularly the U.S. as we build out our public health infrastructure and informatics to be more responsive in disaster and every day. And I'm thrilled to know how much work even got done in 3 hours today, which sounds as though we're making dramatic progress, which is something that I encouraged the group last night to do, and I'm going to encourage this group to do too, because sometimes in health IT we're a little hard on ourselves and are always looking for the next thing that we've got to get done right. But let's not forget that Michigan has had a really incredible journey around health information technology, in part to all the work that you guys are doing every day on the front lines. This is about a really rapid growth and adoption of certified technology. It's about building infrastructure and health information exchanges and the health information network. It's about using that data to drive better care systems around whether that's for alternative payment models or for your public health data, including a repository that consumers in this state can themselves sign up for and access, which is just a terrific tool for consumer access. All of that progress is something that has been mirrored across the country. So the success that you had in your regional extension centers, your HIEs, your Beacon project happened across the country. And we are now looking at a place where essentially every hospitalization has a digital footprint in the US. We just released some data from ONC last week that essentially 97% of hospitals are using an electronic health record. We know that about 3/4 of physician practices are using certified technology, and the numbers have just climbed year over year, and so is the information about what we're doing with the data. So every year there's more pushing, more receiving, more even better ability to integrate data into IT systems. So a lot of progress there. And Black Book reported a couple of days ago some data that system usability is seeming to improve. We're getting more out of the products that we want. And we know this not just from the data, but from the front lines. I'm going to pick on my friend David Kendrick, who's right here in the front row, who we spent some time yesterday talking. And even in the last couple of years that we've been talking a lot about IT, and he's been helping us at ONC, that the challenges around the CCDA or some of the other technical components have been worked through. And all of that is about public-private efforts to come together and solve what can be sometimes thorny challenges. And I think the biggest thorny challenge that we've been grappling with at HHS is the availability of usable electronic health information when and where it matters. And the when and where it matters it varies. It depends upon who you are, what you think is the most important use case. We've been very focused on delivery system reform in the last couple of years because of the needs and opportunities around continuing to bend the cost curve and really see returns on investment that we have made from the HITECH Act and beyond. But we've also really recognized at HHS that it's time for our policy to move beyond the healthcare system and the electronic health record as the center. And our federal health IT strategic plan we put out last fall that received a lot of really nice feedback from the public sector and from our advisory committee, and that we did with 35 federal agencies, those that run health systems like the VA, those that have to build their own IT systems like, I always like to pick on NASA because people don't realize they make their own IT system, but Indian Health Service, as well as those that are regulators in the space with us like the FCC or the FTC. We came together and set out a vision that this was the new world was going to be about putting the person at the center and seeing that electronic health information was there to support not just their health care, but their health, recognizing that health is much more than health care, that there are needs and inputs that relate to the social determinants where you live, learn, work, and play, to behaviors, to environmental exposures, and even to emerging pathogens. And so the recognition also that the electronic health record is an incredibly valuable resource, and the amount of data that we have built up over the past 6 years is informative and going to help advance the health of the country, but it is but one of many sources that we're beginning to understand, the Internet of Things, but also public health data and person-generated data, whether that's the self-report from responses to questions and even information about housing and transportation. All of this is painting, for some communities already, a broader picture of health and helping to inform public health on the front lines. And we see this as the really exciting use case going forward for public health, for disaster and everyday, but also for areas like science and for system improvement overall. This is the learning health system that Chuck and so many other people have described so well. And I think that we really want to push and accelerate that as far as possible. So just a couple of quick words about policy action, and then hopefully we'll get into some back and forth. I want to make sure that you all understand that our focus has moved from EHR to data. And that's the importance there is that for us, this is about time to move to federally recognized national standards, common standards, so that systems can be not just interoperable at the system level, but the data itself becomes interoperable and can be aggregated to fulfill expectations around things like surveillance or longitudinal health records or value-based payment. Second area is about culture change, that we have heard and learned that sometimes data even if it can move, people don't understand that because they're worried about HIPAA, as an example. And we've spent a lot of energy at HHS working on clarifying guidance and putting out consumer-friendly tools to explain HIPAA to doctors and other parts of the healthcare system, but directly to consumers as well. We want them to start pulling at that data to increase the tension. We have been also working on seeing that there's a cultural expectation around published APIs so that there's doorways to the data and it can flow more seamlessly. And then finally, using all the levers we can to build the business case for data to move. We've been using our payment levers very intensively in that, and Congress is helping us with work like MACRA, the SGR fix, the rule we just put out, which will broaden the expectation around the use of certified technology and some of our technical expectations like APIs to all physicians. But it also gives us a chance around things like blocking attestation for all providers to couple the blocking attestation that we have are asking for from a transparency standpoint from vendors. And a business case also relates to our procurement, and we saw that last summer with the Department of Defense, but we're trying, Carla, to make sure that we're giving clear signals to the private sector, we the federal government, as a provider, as a purchaser, as a developer of IT systems, and as a regulator, that we're leaving plenty of space for innovation, but we want to be clear about the fact that it's the consumer's data, it's there to support their health at the individual level or the community level, and that the use cases go well beyond just healthcare, and that the opportunity is just like right now at our fingertips. And so I want to just thank everybody who organized the meeting running up to today and in through today, and what I know is going to be some great work going forward. I said that one of my dreams, hopefully it's not my only dream, is that everybody in America not only has an electronic health record, but actually has a longitudinal health record, one that's a full picture of your health care and health over time. And I think Michigan has a lot of the right pieces in place to round out that picture. And I think the opportunity for us to demonstrate meaningful use case of public health, not only disaster, but every day, and for Michigan to lead the way for the country to show us exactly what this can work well like, is exciting. It's a way to turn what has been a spotlight of maybe not some of the best things into a spotlight that's on the best about what this health IT community and this public health community is going to do for itself and what it's going to teach others.
Mm-hmm. And I agree with you that there has been a sea change in the implementation and the use of information technology that makes the next level of prevention, detection, and responsiveness possible at levels that we had never conceived of before. Since 2005, HIMSS has published census-level information coming from US hospitals. And starting in about 2008 or 2009, we started collecting that same type of data in ambulatory settings. And one of the very interesting pieces of evidence that we have that supports what Karen is talking about is about the widespread implementation that we now have a solid floor on which to build what was previously impossible but is now possible, is that as of the second quarter of 2011, May 2011 to be specific, was the month in which the first meaningful use check was mailed by HHS, by CMS specifically.
Hopefully we didn't actually mail it.
That is a good question. I'm showing my age. Transmitted. So at that time, based upon the census level data that we have, 3/4 of US health providers were in lower stages of maturation of use of information technology, the lowest being they had none, and the lowest of the, sort of the stage 3 of where they had a clinical data repository, but nothing above that. 3/4 of the US health system excuse me, was in that area. 4.5 years later, as of the end of 2015, 3/4 of the US health system were at the highest levels, stages 4 through 7, where you had physician documentation, nursing documentation, closed loop medication management, virtually a paperless environment in where you are practicing health and healthcare. So that makes it possible. That is some examples of evidence that make it possible to build this new reality in the United States. One of the things that I'm curious about, Karen, you talk about, and ONC has been very consistent about talking about this under your leadership, and of course I know it comes straight from the Secretary and the President, is the consumer is at the center of the wheel. And I'm curious about your experience of how much are people drinking the punch on that statement? I don't know about you, but within HIMSS, conversations can be very supportive of the consumer being at the center, and conversations can be a bit skeptical about the consumer at the center of that conversation.
That's a really good question, Carla. I think I think it would depend upon who you asked, and I would reframe it slightly in a slightly different way, which is to say that there are many important actors in the ecosystem, to use our wonky language. There's lots of us who have an invested interest in producing electronic health information or putting it to use. I think my responsibility as the national coordinator, as a public official, is to every person in this country. So for me, it's pretty straightforward that is my accountability, and it's to see that everyone has an electronic health record that is available to them to engage in and improve their overall health. And the way we see it is that the electronic health record in the first generation is about a healthcare experience. And what I certainly know as a public health person, as a doctor, is that health is more than healthcare. There are many other inputs, and so we have to have a broader picture. And so I think the win at the end of the day is certainly it's an obligation for me, but it's a win for all of us if we focus on that, what I call the true north, because then everyone has to leave a little something at the door and remember this is their data and it's for their health, and at the end of the day, they're the ones that paid for it.
Yeah, thank you. I want to just to check, do we have runners with mics so folks can ask questions? Wonderful. Okay, if folks want to start getting their hands in the air. I see Julia has a question here. We've got another question here. So I just want to make sure mics get over to you. While the mic is coming, Karen told a wonderful story this morning.
Didn't we tell a story about the State Medical Society?
Yes, that's a great story.
Yeah. You know, there's a lot that reminds me about the community coming together in Michigan and in Flint to solve this crisis that reminded me of how we were in New Orleans after Katrina. And our community decided that we wanted to rebuild our healthcare system. We had significantly different challenge than you have here, but we were building from scratch. And in 2005, it was we decided we'd have a four-pronged approach, and one of those prongs was about leveraging health information technology to not go back to paper, but just adopt EHRs and move to interoperability. And we created a charter, actually a statewide charter. Secretary Leavitt, who was secretary at the time, encouraged us to lay out our values, and one of them was about the use of technology and health information technology in medicine. You know, he was a big advocate for health information technology. And I remember, and this was in today's world, you'd say, why would you have to write that down? But it was a charter people signed. But the head of the State Medical Society at the time came to me at one of our meetings in May of 2006, and he had this binder, Floyd Burris is his name, and he came over and he said, I just want to tell you that today the State Medical Society passed a policy change so that we could participate in the charter and the movement for better health care, because we had a policy that said that we oppose the use of computers in medicine. And I still tease Floyd about this. I mean, it was tight. It was like typed on a typewriter in like a 3-ring binder. And I was like, God, Louisiana, let's go. It's 2006. But that kind of, that's sort of a cultural shift. If you just think how, that was 10 years ago, right? That Louisiana sort of made that, and we have just leapfrogged, just like Michigan and many other states, and said, wow, what were we need to go, because this is so much better for our clinical practice and everything else. But
it's just an amazing story that oppose.
I would call that systemic change, not cultural change.
The use of
Yeah.
computers in medicine. Wow.
Well, I didn't
10
get
years ago.
into the debate about are you using CAT scans because there's a computer, IV pumps.
All right,
I was,
who-
and that's my
who has the
people,
mic?
so I'm sorry. I'm a doctor. I'm teasing.
And if you could please introduce yourself.
Oh, sure. Mike Kelly from Trinity Health.
Hello.
Hi. My question, you mentioned the patient as the center of the wheel. We still struggle a lot identifying that patient across all the various systems. And so my dream is to be able to be confident when I'm talking to Ascension or the other healthcare systems, or even within our own organization, that I'm talking about the same person.
Huh.
What do you see as
Identity
the
management.
future of identity management?
Yeah.
And when do you think we'll actually be able to be pretty confident of identifying patients?
So in our, some of you may be familiar that we have a nationwide interoperability roadmap. So in our strategic plan, we laid out things that needed to happen at a high 5-year level, but we laid out a pretty detailed roadmap, went deep in this area, and talked about technology and policy, things that would need to be addressed and change. And in the technology and policy realm is this issue of identity management. There are some reasons that we're unable to directly address it, and some of those are because of congressional limitations that we have. Some of it's resource limitations. I think some of it is logistical if you start to really think about whether we decided that even a voluntary identification, which some members of Congress have now proposed, there's some downline logistics to getting that accomplished, how long it would take. And so as a concurrent strategy, we've been working on getting some agreement. We've proposed agreement around how fine of a point you'd want to put on the correct identity, and what are the right ways to get there, what are the right variables, and how would we collect those and get to that algorithm. And I think that leads me to the sort of private sector involvement. You're aware probably that CHIME has a challenge prize to do this that we've been engaged in, but there are many others, and there are folks in this room who run solutions like Commonwealth and others, some of the chic members and even organizations have their ways, some of which are proprietary, that they've done some identity management. I agree with you, it's a big challenge. We think that we need to concurrently work on whatever Congress is going to think might need to happen, but have the private sector think about solving it. I like what CHIME's doing, and I'll tell you why, because sometimes when you put a lot of us in the room and you ask us to solve something in IT, we pull out our IT tool bag and we try to solve it. And we're going to keep running up against ourselves. We're going to have to probably think pretty significantly out of the box. And I'll give you an example of an experience we had that isn't, isn't going to be necessarily the panacea. But the post office, as you may know, was interested in trying to solve identity management. Mm-hmm. So there's some pretty unusual actors in the space, and I think we have to open up our minds. One more kind of comment about this, though, is there are some in our community who, in the ecosystem, whatever, who think that consumer-mediated exchange is the solution to identity management, right? So if I, as Karen DeSalvo, can know that that's my record, can see it, do open notes, make changes, fix my record, and view, download, transmit, or however through the app to my longitudinal health record, I'll know the accumulation of my records. Where that doesn't necessarily help you is, I think, the deeper records that institutions have that is for medical, legal, and compliance and business purposes. So I wish I had a magic bullet for you today, but that's the strategies that we're taking.
I have a question. Is Adam Culbertson in the room?
Yes.
Where is he?
He's over there.
Stand up. Okay, good. Adam Culbertson. Okay. Adam, you're speaking tomorrow at this event, correct? On identity management.
Patient matching.
On patient matching. Okay. So Adam is working in the Office of the Chief Technology Officer at HHS, and HIMSS has been funding his position for about the last 18 months. And Adam has been working tirelessly and relentlessly on this issue of making sure you got the right Carla Smith, because believe me, as Carla Smith, I get this pretty frequently in the health system.
Thank you for reminding me about that.
Adam has been spearheading an effort to come up with a way of testing your identity management process against a data set, and are going to be rolling it out in the September-October timeframe, Adam, for wider distribution.
So there's still so working actually with ONC, we're still in the early stage working with a third-party partner to build at least a reference data set. So every algorithm out there has some sort of reference data set, and we actually don't have a good one for patient matching. So we're attempting to build at least one viable data set that will give us some sort of insight into how good or how bad we can match. And so if we want to improve the matching, you start with measuring how good it is. And there's a pretty well robust science behind evaluating algorithms, and so we're trying to bring that to the marketplace. So that's one piece of the broader pie that Karen and Carla have mentioned. So you can come find me. I can give you. I could talk for days on this, but I'll turn it back over to these two.
Thank you, Adam.
Thank you, Adam.
So I want to make sure you had somebody that you could really follow up with on.
Julia?
Julia?
Yes, I'm Julia Adler-Milstein from University of Michigan. As many people in this room may know, ONC, you've been tasked with defining measures of operability by Congress by, I think it's July 6th, which for anyone who's involved in measures knows is sort of an insanely short time frame. And so I'm curious to know how close you think the measures will be in being able to measure what you said, is information readily accessible when and where it's needed? And given the fact that the measures may not be where we want them to be by July 6th, what's going to be the process for sort of improving those measures over time, or are we going to be stuck with the best we can do by July 6th?
Julia's one of the many people that I've asked in the last couple of years to help us solve this challenge, and she's got one of the best minds in science, much less in health IT. And so thank you to those of you who gave us feedback in writing and in other ways about how to measure interoperability. I've had the chance to see some of the letters and comments, but not all of them yet. And I think the good news is that people recognize that we're using measurement tools that are I'm forgetting that expression, that thing about the lamplight and you find what's underneath it. So we have meaningful use data as an example, and so we keep reporting out on meaningful use, and there's really much more to measuring interoperability. I think the reality, Julia, is that we're likely to stay pretty near to what we have. At least that's what we're even seeing in some of the letters. Is but that we need to have a process as a community, and this is related a little bit to good movement in the private sector for some of the kinds of efforts that maybe, say, CLAS or some of the individual vendors or HIEs are doing to measure data movement and availability. It's a little bit about our opportunity to see the impact of data availability on decision making, clinical and otherwise. And I think the need to perhaps broaden our sources of data collection. So I think I could preview for you that we anticipate that we are, given the timeline, want to keep measuring. We want to be reflective. So I'm not making a decision until we've had a chance to really look at everything that's been sent in, but I would preview that there's likely to be a process that we will unfold in short order to get people to come together. And this is about, the reason I mentioned some of these other efforts is because putting data out there so that everyone can avail themselves of it, so that we can understand if we're making progress as a country is going to be really important. I mean, even the AHA data, which tells us quite a lot, doesn't tell us how much, for example, even how much. I've sometimes said we should just measure fax transmissions, and when those go to zero, and that would require the business offices to tell us that, then we might be done.
You might be done. Next question.
1 minute.
One over here.
Hi, I'm Jackie Sprout from the Michigan Department of Health and Human Services and Behavioral Health. And my question is related to one of the main challenges that we find with care coordination is that folks with substance use disorders are often left out of the benefits of that. And I'm wondering where you see the revisions going to 42 CFR.
Oh boy. So this is, there's two or three or more stumbling blocks in the behavioral health space. First of all, let me just endorse what you said about how important it is, concurrent diagnoses, and the push that we've had from a payment standpoint around mental health parity and pushing out additional resources for treating for substance abuse, for opioids. efforts we're doing around mental health integration into primary care that runs flat up against or smack up against the IT challenges, which are not only technical sometimes, making sure that there's a technical documentation tool available, but what's the appropriate firewall between the data so that people don't worry they're stepping into 42 CFR issues. Yeah, I know you're aware that we've been, as HHS, doing a lot of work with 42 CFR in rulemaking and trying to see how much we can modernize within the existing statute that we have to meet the expectations. Part of our technology work has been to see, can we use technology as a tool to try to protect people's data appropriately and protect systems from it inadvertently being shared. It may eventually come to a point where we need some assistance from Congress to really make advancements. But this is also, by the way, part of the work we're doing with the National Governors Association to see if we can better at least harmonize some of the definitions across state lines, so that in the mental health space in particular, because the definition of what is mental health varies so much state by state. Mm-hmm. So it's, I don't think we're going to, let me say, we will not have meaningful care coordination and better care until we get them included in the technology tent. So from a technology standpoint, I mentioned what we're working to do, but I think that we've got some pretty significant policy challenge ahead in the next few years.
Thank you for the question. And I want to thank you, Karen, and I thank the audience for your time and attention, and really appreciate, Karen, that you and your team have been able to come into Michigan and spend the time with us. And I want to thank the HIMSS Michigan chapter for all their leadership, and for MiHIN for inviting us to do this session. And have a wonderful rest of your day.
Thanks, Michigan.
Thank you.